Okay, thanks. So I am talking to you from Portland, Oregon, across an ocean and a continent on improving health outcomes for autistic people, AASPIRE's work with the Healthcare Toolkit. So Carol already introduced me pretty much. I am faculty at Portland State University and co-direct ASPIRE. Despite my social work and healthcare affiliations, my degree is actually in systems science. So I study big, gnarly, complex problems that have lots of nonlinearities that are hard to separate out, which pretty much describes every single human social problem that exists. I do intervention research. So I develop and evaluate programs that are meant to help people or make some change in society. And she's already told you my research interests. And I hope very much that through doing research that is engaged with marginalized communities and with people with disabilities, that we can use science itself as a vehicle for change. You do research that's more in alignment with what people want, and then that filters down into policy, into advocacy, into data for people to use in order to get their needs met, and into programs that hopefully are what they want and what they feel helps them. I'm also an autistic person, so I'm kind of an insider researcher. I do autism services research from kind of the inside. So the ASPIRE Healthcare project is it's a huge project, and there's a lot of different parts. So I'm just going to give a little overview of what I'll be covering. So I'm going to start with some background on ASPIRE and on community-based participatory research and what that is. And then I'm going to do an overview of the ASPIRE Healthcare project, which has been our 10-year-long at this point series of studies. And then I'll start unpacking those studies in more detail. So I'll start with the studies that informed the Healthcare Toolkit, and then I'll go through some samples of the toolkit. And then I'll talk about the evaluation we did. And then with the time that's left, you can ask me questions about anything I didn't cover or elaborate all the way. And I just heard that there might be a panel, so we'll see how that goes. So ASPIRE, as I said, has been going for 10 years. It was started in 2006 by me and Christina Nicolaitis, who is my co-director, and she is a physician researcher. So the healthcare stuff, that expertise comes a lot from her. We started when I was in graduate school thinking I was going to be working on robot brains. And she was conducting community-based participatory research with communities of color to improve healthcare and depression care. And she has an autistic child and decided that she wanted to meet me because of a listserv thing. So she contrived this journal club where we would get together and talk about autism research. Well, that didn't last very long because all we did was talk about all of the problems that were existing in autism research. And the more we talked, the more she realized that these were the same problems that are experienced by other marginalized communities, like the communities of color that she was working with. And so we decided pretty quickly that instead of just complaining about it, we were going to do something about it. And that something ended up being ASPIRE, which is a team of academic researchers, autistic people, family members, healthcare providers, and disability service professionals. And we're based at Portland State University. We partner with a number of community organizations as well as other universities and the autistic community at large. And our mission is to encourage the inclusion of people on the autism spectrum in matters which directly affect them, to include adults on the autism spectrum as equal partners in research about autism, to answer research questions that are considered relevant by the autistic community, to use research findings to affect positive change for people on the spectrum. So community-based participatory research is a kind of participatory community-engaged research that it's an approach, it's not a method. So it can be used with any research method. You can do CBPR and have it be quantitative, qualitative, observational, intervention, development, any of that. It was started a while ago as a response to some problems in traditional research, and it came up out of, there's many different flavors of community engaged research, community-based action research types of all sorts. Community-based participatory research actually grew up within healthcare, so it's sort of its flavor. But many of these approaches were a response to some problems in traditional research. For example, ethical questions, issues of power between researchers and research participants, issues of trust, particularly when you have a community that has been exploited by researchers or maybe is stigmatized a lot by research, and they don't trust anymore that the researchers have their best interest in mind. Problems with inclusion or exclusion of marginalized populations, people's voices not being captured. Questions and issues around the validity of methods, results, and interpretation when you don't understand the culture or the sort of functional context of your research participants. It can kind of lead to error in study design and understanding your data. And then finally, problems with implication or usefulness of findings, where sometimes findings will be used in ways that further stigmatize the community or that are simply not helpful. So CBPR, in its flavor, seeks to build an equal partnership between academics and community members. But equal doesn't mean that we do the same thing. It's not like we expect our community members to become statisticians, nor do we expect our statisticians to understand the nuances of autism politics. We equally value the expertise and lived experience that comes from both sides. So throughout the entire process of research, the development, implementation, and dissemination through each stage, the community helps to make sure that the research is respectful, accessible, and socially relevant. They make sure it's meeting their priorities, that it's research questions that they want answered, that it's relevant, that it ensures that instrumentation and study materials are accessible, and that in the end, it's going to actually help their community and what they want. The academics keep the research scientifically sound and academically relevant, make sure that the scientific rigor is upheld and that it has scientific merit and that it's going to build on theory and kind of further science, because if you don't do that, then your stuff for advocacy and your, those things that you're trying to do with the community as well don't stand up as much. So it's an equal balancing act between all of those needs that comes together, and there's mutual respect for what each person brings. And it's not so neat either as academics versus community, because a lot of us straddle multiple worlds too, and that's okay. We can change our hats. So where this came from, the healthcare, why focus on healthcare for adults? Because that's the main thing that we've been doing for years now. So despite growing attention to autism in childhood, resources and services for adults are still scarce. The majority of adult healthcare providers have insufficient training to care for autistic adults. There's the stuff within autism itself that can affect communication and relationship building. That's part of healthcare interactions. And it's a high priority for the autistic community. And there are many things that are a high priority for our community, but this happened to be one that we had academic expertise at the time back in 2006 when we started, because that's what Christina does. She's a public health services researcher. So we ended up seizing on a topic where it was important to the community, but we also had enough academic knowledge in order to conduct credible research, which led to the AASPIRE Healthcare Project, which, like I say, has been going on for a very long time. And we started with some online surveys. There was a big online survey of autistic people and non-autistic people to understand any disparities or inequities that might exist within receipt of health care. We also did a small needs assessment or an informal needs assessment of primary care providers. And then we did a qualitative study where we interviewed people about their experiences using the healthcare system and their ideas for improvement. We took all that information, plus our own experience and expertise, and we developed two things. First of all was the Autism Healthcare Accommodations tool, or the AHAT, which I'll talk about a bunch more, but it's a way of making a customized accommodations letter. And we tested that with some cognitive interviews and a test-retest reliability study. And then we developed the Healthcare Toolkit, which is a website of resources that houses that and a whole bunch of other stuff. And we took the toolkit as a whole, and we did a pre-post pilot with autistic patients and their primary care providers. So going back to that way to start, the AASPIRE Healthcare Survey was an online cross-sectional survey. We used our CBPR process to adapt known validated instruments to be accessible to autistic adults and recheck their validity, and they came out okay. And we compared 209 autistic adults to 228 non-autistic adults with and without other disabilities. And from that, we found a bunch of healthcare disparities. So the autistic group had greater unmet healthcare needs in physical health, mental health, and prescription medication. They also had much greater emergency department use, which is an indicator that the primary care system is failing people. They had a lower use of pap smears, which may be an indication of less use of preventive care. They had lower satisfaction with patient-provider communication and lower healthcare self-efficacy. We also examined a number of barriers. We had a list of 61, I believe, barriers to healthcare. And the autistic group experienced both different and greater barriers to accessing healthcare than both the non-autistic people without disabilities and non-autistic people with disabilities. The top barriers for the autistic group were fear or anxiety, not being able to process information fast enough in real time, concern about cost, facilities causing sensory issues, and difficulty communicating with providers. So we wanted to make sure that we considered accommodations for those top barriers as well as a number of other barriers when we created the toolkit. So then we did the qualitative study. So this was semi-structured, open-ended individual interviews with 39 autistic adults and 16 supporters. And we wanted to understand better about what their healthcare experiences were and their ideas for how to improve them or what might have made something more or less successful. These were conducted in person via telephone, email, or instant message to try to maximize the number of people who would be able to participate. And we used our CBPR approach again to ensure accessibility, to make sure that we were asking open-ended questions that were specific enough to make sense, and that we were including as many as we could. So this is what we found from the qualitative. which was that there was an interplay between patient-level factors and provider-level factors that really impacted success of healthcare interactions. The big themes that came out in the patient-level factors were verbal communication skills, sensory sensitivities, challenges with body awareness, slow processing speed, atypical nonverbal communication, and challenges with organization. The big themes that came out on the provider level were knowledge about autism in adults, whether the provider had good knowledge, whether the provider held incorrect assumptions about individual patients based on autism stereotypes or thinking that one patient would be like another, their use of accessible language, their openness to providing accommodations, and their skill in being able to understand how to interface with supporters. That dynamic existed within the broader environmental context of the system level factors, which were the availability of formal or informal supports, the complexities of the healthcare system itself, the accessibility physically of healthcare facilities, broader social stigma about autism, and other societal issues that affect health, like socioeconomic status. So all of that together was what people described as being within the success of their healthcare interactions. So we got additional input from primary care providers. We did an informal survey, and we learned that providers felt very uncomfortable in their ability to provide quality care to autistic adults, but they also had no plans to seek additional training, even though they would accept a new patient into their practice. So asking them what they might do about that, the majority said that they would search for information on the internet or read a customized report and appreciate patient effort, but they were not interested in additional training. And we also did some qualitative interviews with PCPs. So we took all of that and our own experiences and expertise, and we put that into autismandhealth.org, which is the ASPIRE Healthcare Toolkit. It was developed collaboratively by the team, and both what went in it and how it was set up and the fact of its onlineness, all of that was based on the findings from the prior studies that I just described, as well as input from the team. Which those studies and the team, we sort of tried to help to identify leverage points where we could target an intervention that might be useful and what we included. So the toolkit includes the Autism Healthcare Accommodations tool, or the AHAT. It includes a bunch of information and then some worksheets and checklists and resources that are links out. So this is what the homepage looks like, and there's a section for patients and supporters and a section for healthcare providers and links to the AHAT tool. So talking just now about the AHAT tool, the idea of it is that you fill out a survey about things that help you in healthcare, and then the computer program translates that into doctor speak and into a format that providers might find more friendly. So this is what the patient survey side looks like. There's sort of different steps that or parts of accessing healthcare, and then there's questions about what things might help you. And this is what ends up coming out the other side, which is this formatted, bulleted, lots of white space. We heard from providers that it had to be short, it had to have bullets, it had to be really easy. So this is the provider, this is just a portion of what the provider report looks like. This is the patient information, the table of contents. There's a section on healthcare that includes how to find a provider, make an appointment, prepare for a visit, have a visit and follow up, including scripts for what to say, information about health, nutrition, exercise, recreation, preventive care, a bunch of stuff about civil rights in healthcare, autism information geared toward adults, and some other sort of links and stuff out. And we included in here things that our team felt were really important, like how do you make an appointment when you don't use the telephone? So it's kind of customized to our needs. This is the provider table of contents. There's how autism can affect healthcare, tips for successful visits. A lot of that came out of our qualitative pre-work. More legal and ethical stuff, more autism information only geared for providers, and then links to patient resources. And the forms and worksheets include making an appointment, what to bring to a visit, the symptoms worksheet to sort of understand what doctors want to know and what they mean by the questions that they're asking to kind of fill out and organize before going in. An after visit worksheet to organize the stuff that might have to happen afterwards, and another link to the AHAT. So when we did the AHAT, we did cognitive interviews with autistic adults, supporters, and PCPs, and didn't really find many problems. We made some small changes based on feedback. People felt it was easy to understand and important, and our test-retest reliability was adequate. So the Toolkit evaluation, this is the last of the studies, and this was the big one that we just recently finished. And so this was a mixed method, single arm pre-post intervention study in a real life setting. And what we did was we asked autistic patients to complete a pre-intervention survey. They could either do that directly or via supporter. And then they used the AHAT to create a personalized report and could give us permission at the end to send the report to their PCP. And then after that, they were given access to the entire toolkit. And then 1 month later, we did a post-intervention survey of the autistic participant, and if they had given us permission and we'd been able to contact the PCP, a survey of the PCP. So recruitment for that went out to listservs and social media and announcement lists. To be eligible, you had to be 18 or over, have a diagnosis on the autism spectrum, live in the US, and have a PCP. For the data collection, we used many of the same instruments that we used on that original first healthcare disparities study that we did. So we used the healthcare self-efficacy scale, a much abbreviated version of the barriers to healthcare, the patient-provider communication scale if they saw their provider in that month frame, and then some open-ended questions about their satisfaction with the toolkit. We did a brief survey of PCPs who we had sent the reports to. So we had a pretty wide variety of participation types with independent, with support, or via proxy, variety of living situations, and a pretty even range of amount of assistance required to receive health care. We had 126 adults complete the pre and post. They found it easy to understand, important, useful. They would recommend the toolkit to both a friend and to a healthcare provider. And the PCPs also felt that it was useful and that they would recommend it to other patients. And then as far as our outcomes, we were actually very surprised after a month. We weren't expecting to see a change in outcomes, but we actually did. We saw a decrease in barriers to healthcare that people reported, an increase in healthcare self-efficacy, and an increase in patient-provider communication. So we were pretty surprised by that. But the open-ended questions that we asked gave some insight. So in the qualitative themes in that open-ended piece, one of the biggest themes that came up from patients was that the toolkit gave them a means to clarify and communicate their needs. So this person said, filling out the survey helped me clarify some things of which I was only vaguely aware. It also helped put into words things that I am unable to communicate because I cannot think of the right words. Another theme that came up was that the toolkit validated their experience and empowered them to better self-advocate. This person said, it was validating. Previously, I felt that some of the things I was doing, like bringing support with me, was a sign of weakness. Now I view it as part of accommodation. It also gave me some ideas of things to try that I hadn't thought of. Some people talked about how it improved their self-efficacy, particularly by helping with visit preparation. So this person says, it takes away a lot of my uncertainty about the appointments, whether I'll bring up everything I want to bring up, whether I ask the right questions about follow-up care and being prepared for talking to new doctors. It's a game changer for me. We got, from most people, enthusiasm about their hopes for the effect on the provider. Someone said, y'all sent the things to the doctor, so maybe this time he'll listen to me. We did, however, have a minority that was concerned about getting a negative response from their PCP. This person said, when I asked my psychiatrist not to use air fresheners, she said she had to or else her office smelled, and she acted like it was a really big burden on her. I think that if I handed your nice letter to my physicians, they would think I am asking too much of them. I already stand out. I don't want to stand out more. We also got people who had been to see their provider during that 1 month did give us some examples of actual changes that occurred. This person says, I brought a copy of the accommodation letter in case he had not received it. He had, and it was already scanned into his computer. He went over it with me and did what had been recommended. I was reassured by the doctor taking the accommodation letter seriously. I felt like some of the difficulties I experienced were addressed and that they wouldn't have been had I not made use of the healthcare toolkit. Another person said, the visit was very productive and my care moved much faster than previous times. I also did not have to repeatedly call back to check on the status of my referral or find out my results. The office actually called me first with the results. And one more. I think the toolkit validated that my concerns and my daughter's, quote, issues, sensory, behavioral, etc., which often presented during medical appointments, were typical for ASD patients and should be accommodated. From the PCPs, most of them appreciated the toolkit. One of the PCPs said, extremely helpful. What I needed were specific but concise suggestions regarding how to make my patient more comfortable. The report will be in her chart and I will use it at each visit. Some PCPs, however, said that they did not need it, mostly because they already knew their patient well. And 2 out of the 41 providers said that they did not have time for it. So our CBPR process resulted in a highly accessible and usable healthcare toolkit. The toolkit has the potential to decrease barriers to healthcare and improve healthcare self-efficacy and patient-provider communication. And really interesting to me anyway is that the changes may have been driven by changes in self-awareness and self-advocacy based on just reading stuff, as well as the changes in patient and provider behaviors that we were hoping would come from using some of the accommodations. It's had some limitations. The focus was on the toolkit development and this really preliminary sort of feasibility, acceptability evaluation. We need obviously to do a larger randomized trial in order to assess the effectiveness for real on health outcomes. We had non-systematic recruitment methods. It was a convenient sample, and we only got a modest response rate from the PCPs. So implications, first of all, please use the toolkit. It's available for free at autismandhealth.org. The tools may also be helpful to other patients with disabilities or people with low health literacy. Health systems should find ways to incorporate similar tools, if not this one, into clinical practice. And important to me with my science for systems change mantra is that other groups attempting to develop interventions for marginalized populations or for autistic people should consider using a CBPR approach. So you don't have to copy this down real fast. This is a list of everything that's been published about those studies that I just related. And at this point, we've pretty much got something out on everything I talked about here. If you don't get a copy of the slides, you can email me. I can give you this citation list. I can send you copies of the paper. I can send you copies of any of our papers. They're listed on our website as well. I want to say a thank you to all of my ASPIRE team members who have been doing all of this work for all of these years, and to our community partners, the Autistic Self-Advocacy Network, also to the Oregon Commission on Autism Spectrum Disorders Healthcare Subcommittee that provided especially a lot of assistance around the provider letter format, and of course to all of our study participants and the people who supported them. And also our funders, the National Institute of Mental Health. So that was a lot of stuff, and I'm not sure which pieces you might be most interested in, if it's the CBPR stuff or the healthcare stuff. I can do my best on. We'll have some time now. Also, I'll leave this information up. There's my email if you want to contact me, and also you can learn more about ASPIRE and the link to the toolkit. So thank you.